Greetings, it is Miss Marcum and it is time for another exciting lecture. Get your papers, get your book, and let's get started. The ability to maintain good musculoskeletal health, the ability to recover quickly from musculoskeletal injury or disease will contribute to your overall health, wellness, and quality of life. Fractures, sprains, strains, and dislocations account for nearly half of all musculoskeletal injuries. An estimated 7 million Americans suffer a sports-related injury each year. In the next several lectures, we will discuss the biologic response to trauma and examples of how primary diseases and other organs affect the musculoskeletal system. We will also begin to review the local and systemic effects of exercise. Did you know that 3 weeks of bed rest is more detrimental to the body and our physical work capacity than 3 decades of aging? Of course you knew that because you read the chapter. With that in mind, it's really important that we keep our patients moving, especially if we work in settings like acute care or skilled nursing facilities where the patient's mobility is very limited. Just like age is a factor, gender is also a factor. Women double the rate of injury during ovulation because of the increase in estrogen levels, whereas men will increase their muscle volume twice as fast as women, but they also experience a greater loss of muscle mass with inactivity. Let's review a few things. What is the body's biologic response to trauma? Inflammation. What are some clinical findings of acute inflammation? Redness, heat, swelling, pain. We may also see muscle spasms, loss of function, and an increase in muscle tone with that muscle guarding response. How do you expect your patient will move that injured area? Just like you or I would, they're going to move it very slowly and very carefully. It's going to be guarded. Edema is the excessive accumulation of interstitial fluid. That's fluid that's outside the joint capsule and outside the cells. It can be local or it can be generalized. In the cases of inflammation, we've learned about local edema. Injury to the area will cause swelling in the area. And nowhere else. We don't swell in our head because we stubbed our toe. Generalized edema, on the other hand, takes place systemically. Let's just start by discussing some of the effects of generalized edema. That would be shortness of breath, ankle swelling, nocturia, which is you wake to urinate. As you're reading these chapters, you'll see that there are a lot of words that you will be unfamiliar with. I have provided a link in the course content that will take you to a medical dictionary to define the words and pronounce them for you. Orthopnea, shortness of breath that occurs when lying flat. This can also cause the person to need to sleep propped up in bed. But wait, there's more effects to generalized edema, such as decreased urinary output. That's because all that extra fluid is going into the body. Weight gain, a lot of water retention, you'll gain weight. Labored respiration, that extra weight on the lungs or even fluid in the lungs is going to cause that labored breath or shortness of breath. Changes in blood pressure, such as orthostatic hypotension. If fluid is leaving the vascular space and going into the body, the blood will become more viscous, causing the blood pressure to drop. It'll also make the heart rate increase because the heart's going to have to work harder to push that thicker blood around the body. During orthostatic hypotension, the patient's systolic blood pressure may drop 20 points or millimeters of mercury, as well as being accompanied with an increase of heart rate of 15 beats per minute or more. Another presentation is abnormal lab findings. See Table 2.5. Here you'll see the side effects of abnormal potassium, calcium, sodium, and magnesium imbalances. All of these can be very detrimental to many different body systems. For right now, let's just take a look at the musculoskeletal impacts. With low potassium, we have all experienced leg cramps. We will also experience muscle fatigue and weakness. And with calcium imbalances, they may experience paresthesia, severe muscle spasms, and painful cramps. In this class, you're responsible to know the effects on the cardiovascular system, the GI system, musculoskeletal system, the respiratory system, and the cutaneous system. I'm also going to reference you to box 2.6, the clinical manifestations. This gives a nice broad overview of what you will see with the fluid and electrolyte imbalances. When enough fluid leaves the vascular space and enters the interstitial space, the patient becomes at risk for shock and vascular collapse, which would be followed by death. When tissue undergoes major damage, potassium is released from those damaged cells, and that can then enter the vascular fluids, causing hyperkalemia. This can lead to cardiac arrest. You'll see more about hyperkalemia in the table 2.5. There's a few ways we might talk about generalized edema. One of them is called pulmonary edema. And in this situation, the excessive fluid shifts from the vascular space into the pulmonary space, whereas generalized fluid retention will result in pitting edema. This can result from systemic diseases like chronic heart failure, lymphedema, and hepatic cirrhosis. We will be discussing those in greater detail when we explore each type of pathology. Part of the role of the physical therapist assistant is to be able to document these changes in an objective way. Let's talk about how we document edema. The following scale is usually used to assess lymphedema. You will not find this chart in your book, so pay attention. The assessment works like this. You would firmly press your thumb into each extremity for at least 2 seconds, and then you look. Does a pit remain where your thumb was? And if the answer is yes, you would use this scale with counting to seconds to determine which level of edema they present with. With types 1 and type 2, you may or may not see a gross deformity of the limb, whereas with type 3 and type 4, you will definitely have a visual that that limb is swollen and pitting. I have on numerous occasions witnessed pitting edema leak exudate, so you may see exudate kind of oozing out of the pores of the skin because so much fluid is underneath it, it just can't hold it. Let's talk a little bit more about local edema and the local effects of tissue swelling. As we know, we're going to expect to see color, skin, and temperature changes, as well as a loss of range of motion and the presence of pain. Effusion refers specifically to fluid in the joint capsule. Local effects are caused by damaged tissue. It could just be the presence of a burn, surgery, or trauma. The interstitial space surrounds each cell and it's filled with interstitial fluid. Interstitial fluid provides the immediate microenvironment that allows for the movement of ions, proteins, nutrients, and everything else that can cross the cell barrier. This fluid also carries waste away from the cells. This interstitial fluid provides a great service. However, too much of anything can be a bad thing. One of the ways we assess the severity of the injury is to engage the patient in passive range of motion. They may experience muscle spasms, muscle guarding, or they will just complain of pain before you're able to get to the end of their available range of motion. Whether the edema is there because of acute inflammation or because of things like lymphedema, there are several techniques we use to document the patient's progress or regression. We will serially take these measurements. What does that mean? It means we're going to take them every time. They should always be taken bilaterally because you need to compare the swollen side to the normal side. It's not enough that you know it's swollen. The documentation must reflect in an objectable way that it is swollen, and the only way to do that is to compare it to the other extremity. You will also need to document any changes in color, the skin appearance, any leakage, and assess that pitting level. Turgor is on the opposite end of the spectrum. It indicates too little fluid in the tissue. To test for turgor, the therapist will pinch the skin and pull it away from the muscle belly and then release. If that tinting appears, then there is turgor present. There is too little fluid in the tissue. They are dehydrated. Time to define some more terms. Let's start with atrophy, as you're going to hear this one a lot. It is a reduction in the cell and organ size. In the muscle, this occurs because of malnutrition or vascular insufficiency. It can also occur due to reduction in hormone levels, chronic inflammation, pain that limits function, lack of use or immobilization, or neurological factors such as nerve damage. Age is going to come up a lot, and age is another factor that contributes to atrophy because of bone loss, muscle wasting, as well as brain cell loss. Pathologic atrophy is a result of cell injury. So if you've ever had surgery or knew someone who did, you will usually see the muscles in the area atrophy. For example, when my husband had his labrum repaired in his right arm atrophied, but since then has recovered. Hyperplasia is an increase in cell number, and because there are now more cells, it'll increase the size of the organ. A classic example of this is caused by a hormone imbalance. When there's prolonged exposure to estrogen, it can result in endometriosis. So here the endometrium has increased in size because of more cells. Hypertrophy is different. This is an increase in the cell size itself. This can also cause the organ to grow, but is because the cell is now larger. This occurs when increased demands are placed on the tissue, such as exercise. It'll make our muscles, cells grow bigger. But pure hypertrophy will only occur with striated muscles. This includes our skeletal muscles and also our cardiac muscles. And that is because these cells are not capable of dividing. They can only grow larger. For example, hypertrophy of the left ventricle is a typical complication of hypertension, and that is because the heart is working harder. You will get all the details you care to have on that process when we go into cardiac. Our body will go through many changes as we age. For adults, exercise offsets muscle loss associated with aging. It is also shown to improve bone health, which will decrease our risk for osteoporosis. It'll improve postural stability, decreasing our fall risk, increase flexibility, improving our range of motion. Evidence also suggests many psychological benefits, such as boosting our feelings of self-control, self-determination, and confidence. So sarcopenia is the loss of muscle mass, strength, and endurance in the metabolic quality of the skeletal muscle. There will be impaired regeneration of the tissue, and this occurs as a natural part of the aging process. Muscle mass is lost at a rate of 4 to 6% per decade after 40 for women and after 60 for men. The rate will be higher with a history of inactivity, illness, and the process will speed up again after the age of 70. Studies note that muscle strength can be maintained with training, so that's really promising. Exercise can offset these effects well into our 80s. Pause this lecture and go watch the video Amazing 94-Year-Old Gymnast to see the potential that we have despite aging. You will see the following words a lot: etiology and pathogenesis. Etiology is the cause of a condition. Pathogenesis is the manner that the disease develops. So let's talk about the etiology of sarcopenia. We are unsure how much of it has to do with the normal aging process versus how much it has to do with just decreased activity. It's probably a combination of both. But looking at that 94-year-old woman, it gives me a lot of hope that muscle loss is within my power, your power, and our patient's power to control. Pathogenesis, the path of the disease, where it leads over time. Scientists are looking to identify the molecular chain to reverse sarcopenia. Apparently, there is a gene for lazy. I joke, but clearly we have some control over this. They predict that the muscle function may be impacted due to a decrease in the number of the total fibers, or a decrease in the size of the fiber, and or an impaired excitation or contraction response. As we age, there is a decrease in the basal metabolic rate, which contributes to the development of diseases such as diabetes mellitus type 2 and osteoporosis. But exercise can slow or reverse those age-related physiologic changes that occur in muscle. This is best accomplished with resistive exercises. 2 to 6 sets of 8 reps at approximately 80% of the person's 1 rep max. You'll learn about that in Rehab 1, but 1 rep max is the maximum amount somebody can do 1 rep in. You want to take it down to 80% of that and have the patient go through at least 8 reps for 2 to 6 sets. The best methods for fitness and to counteract sarcopenia is to combine appropriate high resistance training with aerobic exercise and a strengthening program. These activities can improve glucose uptake and reduce the risk of diabetes mellitus. Beginning in our middle age, there is a progressive loss of flexibility and changes in our connective tissue that start to contribute to joint and connective tissue issues. Like sarcopenia, it is unclear if this is biological or due to inactivity. But we do know that weight bearing, stretching, and strengthening will improve the health of the tissue throughout a lifespan. Fibrinogen is produced in the liver. It's a protein that is normally circulating in our blood and it's ready for injury. It's part of blood clotting. As we age, though, it can accumulate in the muscle cells and in our fascia, leading to stiffness. This will cause temporary adhesions that will stick to cellular structures, but they are easily broken down with movement and activity. Additionally, our collagen molecules will also age, and they become more stable, but they also become less flexible. Articular cartilage will start to hold less water in the matrix. This will make it easier for the tissue to break down, leading to arthritis. Newer inventions such as glucosamine chondroitin supplements and viscose supplements attempt to combat these changes. Proprioception. Proprioception is described as sensations generated to increase our awareness of joint orientation at rest and motion. Or it's the sensory input and feedback that tells us about our body position. Its receptors are located within our muscles, joints, ligaments, tendons, and connective tissue. It is one of the deep senses and could be considered the position sense. It also declines with age, particularly in the knee and the ankle. I want you to close your eyes and touch your nose. If all is working properly, you were able to touch your nose. Now, I want you to find your fingertips. So close your eyes and raise both your hands high above your head. Keep the fingers of your left hand totally still, no wiggling. With your right hand, quickly touch your index fingertip to your nose. Now take that right index finger and touch it to the thumb of your left hand with it still in the air. Return back to your nose, go to the index finger, back to your nose, to the middle finger, and keep going down the line. Now switch hands and try the other side. Pause the lecture while you do that. How successfully did you locate each fingertip? Did you improve with time? Was there a difference when you used your right versus your left hand? If you try again, but this time you wiggle your fingers of the raised hand while you're doing it, you'll do much better. Let's do a few more activities for proprioception. Make an X on your PowerPoint with your pen, and then raise your pen high into the air. Closing your eyes, bring the pen back down and try to put a dot on the paper as close to the X as possible. Open your eyes and check your work. Now repeat this at least 2 more times to see if you improved. Pause the lecture. For a final activity, you can get a piece of lined paper and write the word proprioception across one of the lines. On that same line, I want you to write proprioception again, but this time with your eyes closed. Then open your eyes and check your work. So what's going on here? In all of these activities, you're using proprioceptors in your muscles, tendons, and joints to judge your body position. Since most of us are highly dependent on visual cues for judging distance and position, these activities may not be completely accurate when we remove our vision from the scenario. Wiggling your fingers in the first activity provided additional information for your brain, which helped it to correctly locate your fingers in space. You'll also notice that practice can help. We can improve our awareness of our position in space without visual cues with practice. At this time, I'm going to ask you to pause the lecture to listen to the video, "The Man Who Mistook His Woman for a Hat." This is a silly video, but it is about what happens when people lose their sense of proprioception and they are no longer aware of where their body ends or where it begins. I'll see you back here after the video. From your previous anatomy classes, you should be able to name some functions of bone. For example, it's a storage space for calcium, phosphate, sodium, and magnesium. It hosts the hemopoietic bone marrow, so growth and development of the elements of blood takes place in our bones. Bones protect our visceral organs, they protect our nervous system, and they supply support for the trunk, extremities, and tissue structures. Bones remodel throughout our life. However, bone density will reach its peak in our 20s, and it will remain stable for about another 20 years. Reabsorption and rebuilding do not keep pace as we age. It puts us at greater risk for osteoporosis. For women, this occurs around the time of menopause because declining estrogen levels lead to rapid bone loss during the first 10 years after menopause. Bone loss in men occurs at a slower rate. Genetic factors are also likely to influence the rate. What do you think osteoporosis puts aging adults at risk for? Fractures. Now it's time to get a little bit more into the nitty-gritty of pathology, and we're going to start by talking about bone. Bone is composed of a meshwork of collagen fibers inlaid with calcium and phosphate. There are 2 main types, trabecular and cortical. The outer surface of the bone is composed of cortical bone, which is also referred to as compact bone. It is found primarily in the shafts of the long bones. It comprises about 80% of the skeletal mass. Trabecula is spongy or cancellous bone. Bones rich in trabecular tissue are more active metabolically, so they have greater loss of structural integrity during aging. That is likely the reason fractures occur more often in the vertebra, the metaphyseal segments of the long bones, and the calcaneus, as these are spongy bones. Remodeling. Bone is a dynamic tissue, and it is continuously being broken down and reconstructed in response to influences like structural stress or the body's requirement for calcium. Calcium is used to regulate our heart rate, it's for muscle contractions, blood pressure, and many other system functions. Remodeling is needed to protect the structural integrity of the bone and to serve as a storehouse for calcium and phosphorus. You may recall from earlier that osteoclasts are the cells that clear. Osteoclasts are responsible for the absorption of bone, while osteoblasts are responsible for secreting bone matrix. Osteoblasts are responsible for bone formation. Women may start to lose bone mass as early as their 30s, while men will experience bone loss after their 60s. Bone demineralization can lead to osteopenia. Osteopenia is low density, but it is not so low that it is considered osteoporotic. This happens with deficits in hormone levels, inadequate physical activity, so there's not enough mechanical loading, and with poor nutrition. Mechanical loading may be the only stimuli capable of inducing modeling in mature bone. It is crucial to bone modeling. This is why physical activity is so important in young people, and their bones respond favorably. We gotta get their bones set up for success throughout their lifetime. Osteoporosis is a combination of decreased bone mass as well as micro damage to the bone structures, which will result in an increased susceptibility to fractures. Osteopenia and osteoporosis develop when new bone formation falls behind bone reabsorption. Fractures related to osteoporosis are estimated to be around 1.5 million annually. The most common locations for these types of fractures are the vertebra, the hip, and the wrist. Let's distinguish between primary osteoporosis and secondary osteoporosis. Primary is the most common and it affects both genders. It can occur at any age, but it will usually occur in women following menopause and occur in older men. Secondary osteoporosis is induced by outside factors such as medication, another disease, or some other condition. I will now refer you to box 17.1 in Chapter 17. It is risk factors and conditions associated with osteoporosis. You'll see modifiable risk factors as well as non-modifiable risk factors. You're responsible for the information in this chart. I'm sure at a quick glance you can see there's a reason why I'm not just reading these things out to you. I have, however, already discussed many of the factors listed in this chart, but you will see other things that I haven't mentioned, such as smoking. Pause the lecture and read this now. There are new technological advances that are currently under investigation that include implants in the bone that could stimulate growth. They have now been working on injectable bone, synthetic muscle regeneration, and new plastic materials to replace spinal disc and for use in joint replacements. All of these advances are very promising. I do think that it is worth our time for me to cover some of these factors in greater detail. Let's start with hormonal status. We have already fleshed this one out. Being a female and being postmenopausal will greatly increase your risk. Heredity and genetics. As mentioned, we get our peak bone mass somewhere in our 20s, and the rate of breakdown is partially genetically determined. Body shape and size will also play a role. Thin women will have less cortical bone. Obesity is somewhat protective due to the higher mechanical stresses that are put upon it because of the added weight of adipose tissue, and adipose tissue helps store estrogen. Ethnicity can be a factor, as bone mass correlates with skin pigmentation. People with white skin generally have less bone mass than people with black skin, and black men have longer, wider bones than white men, placing them at the lowest risk for developing metabolic bone disorders. Physical inactivity results in less gravitational and muscular forces acting on the skeletal system. Disuse from bed rest, casting, lack of motivation, long-time care, all these things will impact cellular function and lead to osteopenia. As mentioned, tobacco and alcohol are associated with a reduction in bone mass, including caffeine. Medications. We already talked about corticosteroids as they are an immune suppressant. Immune suppressants are going to have an impact on bone metabolism. Long-term use of some medications will put our patients at risk. Depression. Lower bone densities and high levels of cortisols are common in individuals with a history of depression. Cortisols help us deal with stress, but too much of it causes increased belly fat and decreased muscle mass. Loss of appetite is also common with depression, and it may also be a nutritional contributing factor. Segue into diet and nutrition. Good nutrition, including calcium-rich foods and vitamin D, is needed. Bone density decreases in women with very low body weight, so those with anorexia or bulimia, and also ballerinas and other people that starve themselves. The new term, female athlete triad, describes the combination of an eating disorder, amenorrhea, which is the absence of menstruation, and osteoporosis. Youth and activity alone will not protect us from osteoporosis. We need nutrition. Compression fractures are the most common fracture with osteoporosis, and it is sometimes the first symptom. The prevalence is 20% for women over 50 and 64% for older women. They can happen anywhere, but the vertebral bodies, hips, ribs, radius, and femur are the most common site, and in that order: vertebral bodies, hip, ribs, radius, and femur. The silent fracture is the vertebral fracture, and it is the most common. What are the signs you may see? Remember, signs are something you can see. It is not something that is perceived, it is visible. Or data can be collected about it, such as high blood pressure. You can't see high blood pressure, but you can certainly take a high blood pressure reading. I'm going to encourage you to stand up and try to get into the following posture, as these are the signs you will see for decreased bone density and possible compression fractures. You will have a forward head, so look at the floor. Marked thoracic kyphosis. Do your best to round your upper back. Now relax your abdominal wall and push your tummy out a little bit more. Try to eliminate your natural amount of lordosis by putting your pelvic into posterior tilt. Hyperextend the knees, internally rotate the shoulders, supinate the forearms facing your palms to the back. Pretty uncomfortable posture to be in, and it stands out. The symptoms are things the patient perceives. They're things that we cannot see and we cannot get objective data on. For example, back pain. The pain is there, but we can't see it and we can't measure it. Only the patient can tell us how they perceive it. They may also report perivertebral muscle spasms, so little tiny muscle spasms in the back. Another very important thing to recognize is that these compression fractures can be asymptomatic. They may have absolutely no idea that they have a fracture. So to put it simply, you will see things such as postural changes, loss of height, back pain, fractures, and a Dowwager's hump. The Dowwager's hump is pictured here. Osteoporosis is diagnosed with an X-ray. Oftentimes, the patient will come in for a fracture and they'll get an X-ray for that fracture, and it is at that time that they discover whether the patient has osteopenia or osteoporosis. What do you think their pain will be like? Do you think someone with a vertebral fracture will have localized pain, or do you think it will be generalized? It would be a localized pain around that fracture site, and it may be severe. And if you palpate it, It would be tender to the touch. The pain may also radiate into the abdominal or the flanks and get worse with prolonged sitting, standing, or bending, or with the Valsalva maneuver. If you don't know what the Valsalva maneuver is, it's when people hold their breath upon exertion. Here's some food for thought on generalized bone pain. It is suggestive of metastatic carcinomas or osteomalacia. But I won't open that can of worms too much for the moment. Just understand that generalized bone pain is not associated with compression fractures or osteoporosis. It will be site-specific, localized. When you have a patient with osteoporosis and you are developing their plan, there is a lot to consider. The doctor will minimize the use of medications that are known to cause bone loss, and the therapist needs to be concerned about their risk of falling. We need to provide patient education and recommend assistive or adaptive devices for their stability. We also need to be very mindful that we do not pick interventions that lead to more compression fractures. If you suspect that they have compression fractures, you should send them to a doctor for assessment. Pharmacological management. While we don't prescribe medications, we still need to be aware of what they are. The doctor may prescribe bisphosphonates. These can decrease bone reabsorption. However, they do not induce new bone growth. The side effects of these types of medication include constipation, nausea, flushing, leg cramps, or GI intolerance. All of these factors can have an impact on the patient's ability to engage in therapy. Hormonal therapy. Estrogen can be provided for women and testosterone for men. But before we get too excited about that option, see Box 17-4 for a list of side effects associated with estrogen, such as headaches, chest pain, groin or calf pain, high blood pressure, edema, and even tremors. Nutrition. These patients will benefit from vitamin D synthesis. It is essential for bone formation and it influences many other organs and cellular functions. Deficiency results in poor intestinal absorption of calcium. Vitamin D deficiencies are associated with diseases like rickets, which is a failure of the bone to mineralize. It is associated with bone and muscle pain as well as low energy. We make this vitamin naturally just by being in the sunshine. We can also get it through our diet by eating things like milk, fish, and eggs. Unfortunately, deficiencies are becoming more common. We tend to avoid the sun. We have milk allergies. We eat vegan diets. So these things are having an impact on our vitamin D. Having darker skin may also have an increase in a risk for a deficiency because more UV exposure is needed. Overweight or obese people will likely be needing more vitamin D than the slimmer person because vitamin D is fat soluble. It's a hormone-like vitamin, which means body fat acts like a sink and it just collects it. Some medications can cause decreased absorption of vitamin D, such as corticosteroids, anti-seizure drugs, laxatives, and anti-cholesterol medications. But we can increase our intake through our diet by eating vegetable-based proteins like soybeans, lentils, chickpeas, and black beans. Osteomalacia. This is soft bones. It's a progressive disease in which the lack of mineralization of the new bone results in softened bones without the loss of the bone matrix. So unlike osteoporosis where there's a loss of bone matrix, all the bone matrix is present with osteomalacia, only it's soft and weak. This matrix is considered immature or not calcified. The bone tissue is referred to as osteoid. Softening of the bones is caused by impaired bone metabolism, primarily due to inadequate levels of available phosphate, calcium, or vitamin D. Signs and symptoms can include diffuse body pains, as I mentioned earlier, that generalized body pain is something that you will find with osteomalacia, muscle weakness, proximal myopathy, postural deformity, such as kyphosis or a heart-shaped pelvis, bowing of the tibia and femur, so bow-leggedness, a waddling gait. They may have difficulty climbing the stairs, and in general, the bones are fragile. Osteomalacia is sometimes referred to the adult version of rickets. Patients may develop fractures from microstresses in what is referred to as loser zones. Loser zones are most common on the concave side of long bones. This may also be referred to as milkman syndrome. These fractures will heal with proper care. The primary cause of osteomalacia is insufficient calcium absorption, which could be caused by a lack of calcium or a resistance to the action of vitamin D. Phosphate deficiencies can be caused by long-term use of antacids or long-standing hyperparathyroidism. Because we add vitamin D to milk products in the U.S., it has virtually eradicated this disease. However, it still occurs in the malnourished seniors and those with poor exposure to sunlight and darker skin. Age, being housebound, lack of exposure to sunlight, poor nutrition, malabsorption, medications are all problematic. The most common cause is lack of calcium and vitamin D, and that is usually associated with impaired absorption. Diagnosis is done using many different tests: blood tests, urinalysis, radiographics, and a bone biopsy. The treatment will depend on the underlying cause. For the PTA, you would follow the same precautions for treating this patient that you would follow for osteoporosis. No box 17.5, risk factors associated with osteomalacia. I'm going to pause for a moment and give you a little study tip for pathology. As you might have already realized, a lot of these conditions are similar. You'll see similar signs and symptoms and similar reasons for why certain pathology developed. What you need to be looking for and understanding is the differences. So as you start to look at these different bone metabolic diseases, what makes them different? And that's why I wanted to point out to you that in osteomalacia, the bone has all the bone matrix, only it's soft, versus osteoporosis, where the bone matrix is missing. And what bone matrix is there is hard. So these are the things that you need to look at so that you can understand each pathology and why it's different. Paget's disease. It is pronounced how it looks. Don't get used to it. Most terms don't work that way. But Paget's disease is a metabolic bone disease that results in an overproduction of weakened bone tissue. This disease often has a genetic factor. The autosomal dominant pattern is mutated. The dominant gene is located on one of the non-sex chromosomes. That means only one gene is needed to affect a person with this disorder. A person with an autosomal dominant disorder has a 50% chance of having an affected child with the mutated gene. This gene makes family members susceptible to a suspected virus. How this virus affects the osteoclast is unknown, but is a slow-acting virus that takes years to progress to the point where symptoms become evident. Yes, that is right. This is a genetic disease that makes the person susceptible to an invading virus. The presentation most commonly affects people over 50. The bone appears enlarged, but it lacks strength due to the abnormal osteoclast proliferation that results in high turnover of the bone. The osteoclasts excessively break down the bone matrix, and the new formation of bone is disorganized. The bone remodeling lacks structural stability. The osteoblast can't keep up, and fibrous tissue replaces bone. The bones are enlarged, but they're very weak, and deformity is common. This disease is becoming less prevalent and presenting later in life with less severe symptoms. This suggests that there might be some environmental factors involved as well. However, it does remain the second most common metabolic bone disease after osteoporosis. It affects 10% of the U.S. population over 70, men and women. It is a progressive disorder of the adult skeletal system, primarily affecting the axial skeleton and the femurs and tibias. Ethnicity appears to play a role as well. The disease is almost non-existent in Asian, Native African, and South American population. It is common to the British Isles and countries where migration from Britain occurred. The pathogenesis often begins with a vague, diffuse body ache or pain in the lumbar spine, hips, or knees. The infected bone or bones can change shape, size, and direction, leading to bone pain, arthritis, fatigue, lightheadedness, general stiffness, and of course, fractures. Advanced progression of the disease includes constant headaches, vertigo, hearing loss, nerve compression, pain, mental deterioration due to reduced blood flow to the brain, especially if the cranial bones have been infected. The leading cause of death for patients with Paget's disease is heart failure. This disease is diagnosed with radiographs and bone biopsies, and the prognosis will vary. The disease may be stabilized with management, but if no treatment is given, rapid progression can occur. The outlook is generally good if treatment is given before there are major changes to the skeletal system. Treatment involves pharmacological interventions using biophosphonates to inhibit bone reabsorption, as well as exercise, weight control, and cardiac fitness. It is also important to note that these patients may experience an adverse drug reaction to anti-inflammatory medications as a drug disease reaction. What are the implications for the PTA? We need to be aware of signs of compression fractures as this patient is a high-risk group. Therapeutic exercises is beneficial and recommended. The mechanical stresses placed on the bones by strengthening will minimize the complications with Paget's. Exercise maintains range of motion, improves cardiac health, and muscle strength. They need resistance and endurance training just like everyone else. However, we must avoid all exercises that put this patient at a risk of fractures. See box 17.6, Clinical Manifestations of Paget's Disease. This is an ideal opportunity to talk more about fractures. We know how fractures heal, but there's a lot more to know. Any deficit in the continuity of the bone from a small crack to a complete break with multiple segments is referred to as a fracture. There are three general categories: traumatic, stress or fatigue, and pathologic. Traumatic is the most common type, and it is associated with sudden impacts such as assaults, falls, or motor vehicle accidents. In general, the upper extremity is most common, particularly for those who are between 5 and 14 years of age. Bone mineral density and age are the most common risk factors for fractures. See box 17.7, Risk Factors for Fractures, for more details. The rate of hip fractures will increase for those 50 years or older and doubles every 5 to 6 years after. Hip fractures account for nearly 38% of all fractures over 65. They are associated with high risk of falls. Your ability to rehab balance will matter. Your ability to make your patient care about improving their balance will matter. You will play a key role in fall prevention by providing education and fall risk assessments to prevent fractures in adults over 60. See box 17.8, Risk Factors for Falls. Stress fractures occur when the bone is unable to withstand the stress applied. They occur because of rhythmic, repeated microtraumas. To put it another way, stress fractures occur when normal bone is exposed to repeated abnormal stresses, or normal stress is applied to an abnormal bone. This kind of fracture is most common with track and field athletes, such as runners or soldiers who are in training. They typically occur in the lower extremities, such as the shaft of the tibia, the metatarsals, the pubic ramus, the femoral neck, and the fibula. The mechanical factor can be either compressive or distractive. Pathologic fractures occur when the bone is fragile because of another disease or a condition like cancer or reduced bone mineral density. These are sometimes referred to as insufficiency fractures. Pathologic fractures are more common among those undergoing radiation, postmenopausal, or those with osteoporosis, whether it is secondary or primary. Weight bearing alone can cause a pathological fracture. It can produce enough traumatic force to compromise the spine. Vertebral compression fractures are one of the most common osteoporosis-related pathological fractures. Signs and symptoms of fractures. Not all fractures are equally painful, but point tenderness over the site of the fracture is usually present with most traumatic fractures. But point tenderness is rare with stress fractures. Pain caused by pathologic fractures of the spine, pelvis, and sacrum is often nonspecific low back, groin, or pelvic pain. So generally speaking, if there's an attempt to move a limb with a traumatic fracture, there will be a pain response. But with stress fractures, they do not generally have pain with active movement. Pain will only become present with resistive forces. The symptoms will be more severe if the fracture is unstable. Stress fractures are a little harder to diagnose. It may take anywhere from a week to several months for one to appear on an X-ray, depending again on the severity. A stress fracture can be identified with a more expensive test, such as an MRI or a CT scan. CT scans are the most effective. In fact, some vertebral compression fractures are detected accidentally during a chest CT. Traumatic fractures, however, are extremely easy to diagnose, usually a visual inspection, and it will be confirmed with an X-ray. And in case there is any confusion, a radiograph and an X-ray are the same thing. Types of fractures. An avulsion fracture. A portion of the bone becomes fragmented at the site of the tendon attachment due to some sort of traumatic or sudden stretch of the tendon. A closed fracture means there was no break in the skin, versus a compound fracture, which means the bone is protruding through the skin. A comminuted fracture means the break is in several fragments at the injury site. Green stick fractures are common among young people, and the break is on one side of the bone, and it does not damage the periosteum on the opposite side. Non-union fracture. A break that has failed to unite and heal after 9 to 12 months. We've already discussed stress fractures, so I'll be brief. It occurs because of repeated microtrauma to the bone. A spiral fracture means the break is in an S shape due to torsion and twisting. Malunion means it healed within the expected time frame, but it healed in an unfavorable position with the residual bone having deformity. For example, when my mother was young, she slammed her pinky in the door, and my grandmother couldn't afford to take her to the hospital, so it healed on its own, and to this day my mom has a crooked pinky. It healed, but it healed as a malunion. A delayed union means that it did not heal in the expected time frame. Open reduction and internal fixation, also referred to as an ORIF. This is used for bone fractures where there is a lot of excessive movement for comminuted fractures. An internal fixation device will be used to hold the fracture stable to allow for healing. This will also maintain the bone in its proper alignment to prevent malunion. This is a surgical procedure where the surgeon must expose the damaged bone and then add the screws and the pins. This is one of the reasons why in procedures you will learn to ask your patient if they have any metal in the area. Heterotopic ossification. This occurs when bone forms in non-osseous tissue. Usually that means in the muscle and the soft tissue areas. It is mostly considered a benign condition of abnormal bone formation in soft tissue. It is most common following traumatic injuries that involve extreme force or blast that will shatter the bone and result in an amputation. During healing, the bone will not grow as expected and it may spiderweb out. There is a rare hereditary component for some cases. HO versus MO. They are terms that are often used synonymously, but there is a difference, and the difference is location. So, when I say heterotropic ossification, I am referring to HO, which occurs in muscle and soft tissue. Myostasis ossification, or MO, deposits lamellar tissue to the bruised, damaged, or inflamed muscle only. There are three classes. Class 1 is the presence of heterotropic ossification, but without functional range of motion limitations. Class 2, there will be limitations in all planes of motion. Class 3, there will be ankylosis preventing motion. Eventually, I will stop defining all of these things for you, as it should be part of your reading process that you stop and you define words that you don't understand, and that's normal. I have to do it even now. But I will go ahead and define ankylosis for you as two bones that have fused together. It's essentially a form of arthritis that primarily affects the spine. Signs and symptoms. Pain and loss of motion are most common and usually develop within the first 2 weeks after the traumatic event, whether it was a burn, surgery, neurologic assault, or trauma. But these patients can also be asymptomatic. Typical sites are the knee, hip, shoulder, and elbow. They may also present with swelling, warmth, arrhythmia, and tenderness. Wait, swelling, warmth, arrhythmia, and tenderness. Well, what does that sound like? Sounds like the inflammation process. Acute symptoms will subside, but motion will continue to decrease, even with interventions such as splinting. This is the hallmark sign of this disease, a progressive loss of joint motion at a time when inflammation should be resolved. Over the next 3 to 6 months, the HO matures and the individual develops an abrupt infield with pain at the end of their range of motion. This condition is diagnosed with X-rays. Management. There may be a need for surgery if there is enough loss of function. Physical therapy will be involved at the preventative level by providing competent wound care, debridement, and to encourage functional use of the joint. We also need to educate the patient about the importance of being active early on in their rehab. After 3 to 6 months, that scar tissue is going to be reorganized and it will become fibrotic, and there will not likely be any more gains in range of motion. It is important that they are compliant early on in their rehab. We will encourage continued strengthening in whatever range of motion is available to them. Sometimes radiation therapy is used as a preventative method for individuals who are considered high risk of developing this complication. NSAIDs have been useful for some areas in the body to reduce the frequency and magnitude of bone formation, particularly in the hip. Osteochondroses is a term that represents a group of disorders with a common denominator, avascular necrosis, and its sequelae, which is another way of saying consequence of disease or injury, and you'll hear it and use it a lot in the medical profession. The most susceptible area is the epiphysis, which is entirely covered by articular cartilage and poorly vascularized. Considering that all of the pathologies that fall in this category have the same criteria of avascular necrosis, You'll need to focus and find out what makes them different. Osteochondritis dissecans is a joint disorder where cracks form in the articular cartilage and in the underlying subchondral bone. That will allow for necrosis and recalcification. When a piece of articular cartilage or a fragment of bone separate from the underlying bone, this is referred to as a loose body. Loose bodies usually cause pain and swelling in the affected joint. It'll catch and lock during movement. Physical examination typically reveals a joint effusion, tenderness, and a crackling sound with joint movement. It is caused by avascular necrosis. Most commonly found in the medial aspect of the knee, the treatment almost always involves surgery. There is a non-operative option for juveniles, but it takes 10 to 18 months to heal, and they have to use immobilization, activity modifications, protective weight bearing, and rehab. It's very involved. Osteonecrosis occurs mostly at the femoral head. It means cellular death, necrosis of the bone and the bone marrow and the cellular components, all due to an interruption of blood supply, ischemia. It accounts for nearly 10% of all total hip replacement surgeries. The next two we will touch on briefly, but go into greater detail in just a moment. Legg-Calvé-Perthes disease is when the epithelium undergoes avascular necrosis of the femoral head. The etiology is unknown. It is a childhood hip disorder initiated by the disruption of blood flow to the femoral head. And what is it called when blood flow is disrupted? Ischemia. Due to the lack of the blood flow, the bone dies and stops growing. Osgood-Schlatter's disease tends to affect boys more than girls between the ages of 10 and 15. It's the repetitive pull of the patellar tendon. It's related to the extensor mechanism. It pulls bits of the immature bone from the tibial tuberosity. It's considered a form of tendinitis. I had this condition as a child and it resolved very quickly, and it was a result of just being a very active child. Siding-Larsen-Johannesson syndrome involves the same mechanism, only it acts on the proximal patella, resulting in fragmentation at the patella. Legg-Calvé-Perthes disease, also known as coxa-plana or flat hip. It is an idiopathic pediatric condition. Idiopathic means I don't know where it comes from. It occurs when ischemia causes avascular necrosis to the proximal end of the femur. It is self-limiting and it occurs in 4 stages that last a total of 2 to 5 years. See Table 17.3. Stage 1 is referred to condensation or avascular. In this quiet phase, the blood supply to the femoral head is disrupted and the bone cells die. The area becomes intensely inflamed and irritated. The patient may begin to limp or find a new way of walking. This initial stage could last for several months. Stage 2 is referred to fragmentation and revascularization. Over a period of 6 months to a year, the body will remove the dead bone and quickly replace it with initial softer bone or woven bone. During this phase, the bone is weak and the head of the femur is more likely to break apart and collapse. Stage 3 is the reparative and reossification phase. In this phase, new, stronger bone develops and begins to take shape in the head of the femur. This ossification stage is often the longest stage of the disease. It can last for a few years. After 2 to 3 years, the patient will then enter stage 4, the remodeling regenerative phase. The bone regrowth is complete and the femoral head is live and spongy bone again, and the femoral head is going to reform. How close the shape is to round will depend on several factors. The first being the extent of the damage during the fragmentation phase, the age at the onset of the disease, The younger they are, the better, as age will have a potential effect on bone regrowth. Any deformity in the epiphysis or any shape of the femoral head can lead to osteoarthritis as a young adult. This disease is more common in boys than in girls and more common in whites than in blacks. Onset of this disease will occur between the ages of 3 and 12 years old. Signs and symptoms. It is an insidious onset. And what does that mean? Slow, gradual, it's sneaky, it's insidious, with intermittent pain that is aggravated by activity and relieved somewhat with rest. There will be limping and changes in gait, soreness and aching with stiffness and in the groin and along the length of the thigh. There will be point tenderness over the hips capsule and proximal thigh atrophy. Goals for treatment. Be aware and limit deformity of the femoral head. The femoral head must be contained within the acetabulum so it can be molded to a normal shape as it heals. In the past, these patients were kept completely non-weight bearing. Now they are allowed some ambulation when maintaining hip abduction, AB, hip abduction, and internal rotation. This will help to protect the head of the femur. There are a variety of splints and braces that are being used, and traction may be used as well. Aquatic therapy is also a useful tool for this patient population. Prognosis. If the onset of the disease occurs before the ages of 4 or 6, the results tend to be good, with or without treatment. The older the child is at the onset of the disease, the less favorable the results, and that has to do with bone growth and age. If the doctor discovers stiffness on examination, especially tight hip adductors, ADD, then the results are not favorable. The patient is usually admitted and placed on traction and physical therapy to relieve the tightness. Contemporary treatments involve containment of the head of the femur in the acetabulum. This can be achieved by using casting, bracing, or surgery. I've included some examples of some bracing and casting on these slides. These are worn for a period of 18 to 24 months depending. Surgery is usually reserved for the older child with more severe impairments. A proximal femoral osteotomy involves cutting the femur just below the hip and redirecting the head into the acetabulum. The osteostomy is stabilized with surgical hardware like plates and screws. A pelvic osteotomy involves cutting a part of the pelvic bone to adjust the acetabulum to redirect the acetabulum to contain the head. At this point, I'm going to refer you to the video Leg Cave Perthes. Osgood-Schlatter syndrome. This syndrome results from fibers of the patella tendon pulling on small bits of immature bone from the tibial tuberosity. It is related to extensor mechanisms. Osgood-Schlatter is most often seen in active boys between 10 and 15, but it does affect girls as well. It is self-limiting and caused by repetitive tension on the patellar tendon. Signs and symptoms would include swelling, point tenderness over the tendon at the insertion point, an antalgic gait, which means painful, a painful gait, and pain with increased activity. Our treatment is conservative. Focus on education, icing, flexibility exercises, eliminating the activities that place strain on the tendon like squatting, running, and jumping. The large quadriceps or your thigh muscles are attached to that tibial tuberosity. During adolescence, when the bone is still immature and is not fully hardened, it's susceptible to the pull caused by the contraction of the quads. So repeated sporting activities that don't allow the bone to rest and adapt will lead to inflammation of the tibial tuberosity. We treat it like tendinitis. Siding-Larsen-Johannesson syndrome is similar. The traction occurs at the inferior pole of the patella, and so the bone fragments are pulled from the patella. So do you think there'll be inflammation? Absolutely. So our treatment will start with rest, ice, NSAIDs, such as ibuprofen, and elevation. In many cases, the condition will get better using only these methods and some rest. In rare cases where the symptoms don't go away, a cast or a brace may be used to support the leg until it heals, which will take about 6 to 8 weeks. Once Osgood Slaughters has established itself, it's very difficult to get rid of, and it may not resolve until the bone is fully matured around the age of 16. Corticosteroid injections are not recommended for this age group. Okay, it's movie time again. Go back to your course content and watch the next video on Osgood Slaughter. Seaver's disease. Seaver is very much like Osgood, only it involves the Achilles tendon and the calcaneus. It's also a pediatric condition that occurs when growth of the bone is taking place at a faster rate than the tendons. This causes the heel cord to be shorter in compared to the length of the leg bone. The heel cord is attached to a portion of the calcaneus. It is still immature and prone to injury. Compounding this is the fact that these changes are happening in a very active child. The end result is an overuse syndrome with inflammation at the heel where the heel cord of the Achilles tendons inserts into the heel bone. It may also be referred to as calcaneal apophysitis. We will treat this condition just like the other one with good old-fashioned rice and NSAIDs. We may also want to address proper footwear. And let's talk about physical therapy. What kind of interventions would be appropriate? Definitely heel cord stretching. Would you consider heel raises an appropriate exercise for this patient? Pause the lecture and think about it for a moment. If we were to strengthen their plantar flexors, we would increase the tone and cause more pulling on that tendon. Instead, we would want to strengthen the dorsiflexors. The act of strengthening the dorsiflexors will help to add length to the plantar flexor. Slipped capital femoral epiphysis. This occurs when the head of the femur slips off the growth plate in a posterior direction. This is also more common with boys than with girls, and the average age of onset is 12, but the ages can range from 10 to 17. 40% of the cases will present bilaterally, and within 18 months of the other. The growth plate is a weak area of the bone that is not fully developed when we grow. In this area we are vulnerable. The etiology is unknown, though in some rare cases the cause was trauma to the hip. Signs and symptoms will include pain, stiffness, instability of the affected hip, and this condition gradually develops over time. Knee pain may be the first symptom. It's important to be diagnosed as quickly as possible. Without early detection and proper treatment, SCFE can lead to potentially serious complications, including painful arthritis of the hip joint. The preferred method for stopping the epiphysis from slipping any further is to place a large screw into the epiphysis to hold it into place. Once stable, the patient is able to walk and weight bear on the affected hip with or without crutches. Most cases of SCFE are stable slips. An unstable slip is more severe. The pain presentation is more sudden. The patient cannot walk or weight bear, even with crutches. Unstable SCFEs require urgent treatment. There's a greater risk of complications such as leg length discrepancy or dislocation. Some of the complications associated with SCFE are chondrolysis. This is rare, but it's a serious complication and one of the common disorders that can affect joint function. In chondrolysis, the articular cartilage on the surface of the joint, usually the hip, will degenerate rapidly. It'll cause pain, deformity, and permanent loss of motion in the affected joint. Although the cause of the condition is not yet fully understood by doctors, it is believed it may result from inflammation in the joint. Aggressive physical therapy and anti-inflammatory medications may be prescribed to a patient who develops chondrolysis. Over time, there may be some gradual return of hip motion. Each surgeon will have their own protocol, and the patient will be followed by that surgeon for at least 2 years to watch for complications. If you treat one of these patients, follow the protocol. Let's end today's lecture by talking about soft tissue contractures. They are named by the action of the shortened muscle. So, for example, if I have difficulty bringing my elbow into extension, then I would have a flexion contracture if a contracture was present. So a contracture is defined as the shortening of soft tissues that prevent normal mobility of a structure. For example, let's say the knee is limited with extension. So what muscle is the contracture in? It would be in the hamstrings. The knee is unable to get into extension because the hamstrings are pulling, keeping the leg in flexion. Myostatic contractures originate in the muscle. It is a shortening of the muscle caused by adapting to the length at which they are habitually used or positioned. So what does that mean? A myostatic contracture is a result of poor posture. So this can be resolved with stretching, a lot of stretching, low load, long duration stretching. A pseudomyostatic contracture is when the muscle is in a constant state of contraction. For example, nervous system lesions, muscle spasms, guarding, and pain can cause a pseudomyostatic contracture. Arthrogenic contractures are adhesions in the joint. So you might be looking at things like rheumatoid arthritis as an example of something that might cause an arthrogenic contracture. So we might see osteophytes in the joint effusion, and irregularities in the cartilage. Periarticular contractures occur when the connective tissues crossing the joint or the capsule lose mobility. This connective tissue affects the arthrokinematic motion of the joint. A fibrotic contracture can occur after a muscle contusion or scar tissue develops in the muscle. Clinically, when someone says contracture, this is usually what they're talking about. Fibrotic contractures are not reversible with stretching or any other therapy interventions. I imagine you all are just as sick of hearing me talk as I am sick of talking. So while we didn't get to osteoarthritis today, I will cover that in the next lecture. Go ahead and try to enjoy the rest of your day. It's important that you go and make time for yourself. For example, I'm about to go read a book about anti-gravity. It's impossible to put down. Good night.